This video demonstrates the technique of laparoscopy assisted Duhamel pull-through for Hirschsprung's disease. The patient was an 8-month-old boy with rectosignoid Hirschsprung's disease, and a junctional colostomy had been performed at birth. The three ports used were an umbilical trocar for the telescope, a right abdominal trocar, and a left abdominal trocar situated adjacent to the junctional colostomy for the hand instruments. So this is the first view inside the abdomen, looking down towards the pelvis, which is occupied by the colon. And this is the right abdominal trocar coming in. And here you see a large fecaloma in the distal sigmoid colon, which, as we all know, is usually arrested at the site of the transition zone. Another feature that was of interest was that the colostomy prolapsed when the pneumoperitoneum was created, and you can see the large gap through which the proximal and distal limbs of the colostomy moved out of the abdomen. This is the left abdominal trocar coming in. It is situated above and medial to the junctional colostomy, which is seen in the background. And this is the large fecaloma at the transition zone, beyond which you can see the narrow rectosigmoid heading into the pelvis. The prolapsed distal limb could be brought into the abdomen by traction. Is the pelvic dissection to mobilize the rectosigmoid distal to the colostomy. The small bowel is moved out of the way, and we were using the power blade, disposable bipolar coagulating instrument, for this procedure. A gap is created in the mesentery of the rectosigmoid, which enables us to do the dissection both proximally and distally. Typically, if there was a fecaloma in the distal limb, it would perhaps be an indication to convert to an open procedure. But as you will see later on, the fecaloma created minor, though not any major, inconvenience for this operation. As is customary, we were using a 30-degree telescope for the procedure. Possibly one of the disadvantages of the bipolar coagulator is the amount of smoke generated, which makes it appear as though we are operating through a fog. So as we do in anorectal malformations, just trying to look at the mesentery from both sides and trying to get a way through to the other side, just inferior to the rectal limit. Once that gap is achieved, the rest of the mobilization becomes a lot safer and convenient. The well-known triangle of dissection being bounded laterally by the ureter and inferiorly by the vas deferens. Dissecting the mesentery on the left side of the distal sigmoid and rectum, and you can see the ureter shining through there. Therefore, the mesentery is lifted away for it to be coagulated and cut. Just there, that's the ureter. And on the left side, as on the right, we stay medial to it and proceed into the pelvis parallel to the bowel. So just behind the rectum there, we can see the presacral space which opens up and which will later be used to create the retrorectal tunnel into which the proximal normal bowel will be pulled through for the Duhamel type of rectoanal anastomosis. Carrying the dissection a little further down the rectum behind it, and we know that this is a safe area in the hollow of the sacrum where there aren't many vital structures. Baby was positioned transversely across the table with the monitor towards the foot end, and the head end was lowered by about 35 degrees. This helps to keep the small bowel out of the way using gravity as the fifth trocar. Now proceeding with the dissection further up the sigmoid colon and coagulating and cutting the mesentery piecemeal. So we switched to the cautery hook for the dissection on the left side of the sigmoid and rectum, and clearing up the mesentery medial to the ureter to get a gap through it from one side to the other. Back again on the right side of the mesentery, and the superficial most layer being cut away there. There you can see the gap under the proximal rectum, which goes from one side to the other, and the first blood vessel to bleed. These vessels tend to retract into the mesentery, so as in anorectal malformations, it is better to keep dissecting until the bleeding point comes clearly into view, and it can then be coagulated under direct vision. So as you can see, the bleeding point is now becoming visible in the form of a small spurter, and that can be coagulated comfortably using the cautery hook. Just a bit of suction to get rid of the accumulated blood. And we can go back to dissecting the mesentery. We are now almost at the level of the distal limb of the colostomy, which has prolapsed outside the abdomen due to pressure from the pneumoperitoneum. And as we progress up the mesentery, this distal limb will be withdrawn into the abdomen so that its mesentery can be dissected off for adequate mobilization. So there you can see a bit more of the distal limb being brought into the abdomen, and this exposes the extent of the cut in the mesentery, which is dissected further up the distal limb. So as you can see, the distal limb of the colostomy is drawn up into the abdomen, and this brings a little more of its mesentery into the working area, and that is then coagulated and divided using the power blade. And in this way we were able to get up the distal limb right up to skin level. And once we got up to the full extent of the distal limb, the same technique was used to mobilize the proximal limb of the colostomy. So that's more of the mesentery coming to the picture and being divided using the power blade. After completing the intra-abdominal component of the dissection, it is now time to mobilize the colostomy, and some lignocaine adrenaline is being infiltrated to prevent subcutaneous oozing. So once the colostomy is completely mobilized, a few lateral adhesions are divided and you have the completely mobilized distal colon in hand. At this point we have removed the trocars and are deciding the site of resection. Now on inspecting the bowel we found that the colostomy was too far proximal into the normal colon, and that such a proximal situation of the colostomy was not needed to bring the normal colon down. The ganglionic bowel was actually present 5 to 8 centimeters distal to the colostomy. Therefore, the decision was taken to close the colostomy and perform the resection 5 to 7 centimeters distal to it. I know this is a unique first time attempt in a Duhamel operation, more so in a laparoscopic Duhamel, but then it is one of the basic principles of surgery that you adopt the technique according to the circumstances prevalent. So there you can see the colostomy being closed with a single extramucosal layer of interrupted polygalactin sutures. So, having finished the closure of the colostomy, it is now time to decide the line of section, and this is judged based on the amount of proximal colon which permits us to get it down to the level of the anus. The mesentery is clamped and divided separately from the bowel. So as you can see, we have chosen the line of section about 8 centimeters distal to the closed colostomy. One may well argue whether it is worth exposing the patient to the risk of another supernumerary anastomosis when two are going to be performed distally. I suppose it's a very personal choice. There would, I suppose, be no harm if the site of the colostomy was excised and the proximal bowel brought down to the level of the anus. Then, using the index finger through the colostomy incision, we make the retrorectal tunnel, and since the baby is small, the finger reaches quite adequately behind the anus, and you can see the tip protruding. A gauze pledget on a forceps is then inserted into this tunnel, and the posterior wall of the rectum being divided here. You can see the gauze getting protruded. Stay sutures are placed in the two corners and the anterior and posterior edges of this incision to keep the edges in view. The suture going into the anterior edge. Now the gauze is used to guide in a forceps from the anal incision to the abdominal incision, which will be used to pull down the proximal normal colon into the anal incision. And there you can see the forceps coming in, the proximal colon being fed into it, and the proximal colon being brought into the incision where it lies comfortably without any tension. The anastomosis is now performed between the end of the proximal normal colon and the edges of the incision in the posterior wall of the anal canal. It's not difficult to see the incision edge in the anal canal. You can see just under the Langenbeck's retractor the anterior edge of the anal canal incision. So that is the suturing being done to the lateral edge of the anal canal incision at the 3 o'clock position. With an adequately relaxed patient, it is well possible to see the edges of the incision in the anal canal and approximate the edges of the colon to them. However, if the patient is poorly relaxed, then the anal sphincter contracts and things get difficult. One of the things you may have noticed as we've gone through this procedure, especially the anastomosis at the bottom end, is that we try to keep the number of stay sutures to a minimum. If you want to operate in comfort, try to keep the number of stay sutures to a minimum, because the more stay sutures you have, the more people are needed to hold them and the more they get in their way. The last few sutures completing the anastomosis towards the 9 o'clock position in the anus, being taken in the anal canal incision and the edge of the pull-through colon. Once the anastomosis is complete, we just make a trial fitting of the stapler. This is a 75mm linear cutter, just testing that one of the blades goes above and the other below the anastomosis to join the proximal colon and the rectum together. The stapler being assembled and fired. Once the anastomosis has been checked, it's time to cut all the stay sutures away and allow it to retract back inside the anus. At the colostomy incision, we now have to remove the remaining part of the distal sigmoid and the upper part of the aganglionic rectum, and this is done by strong traction medially on the colostomy incision, which allows us to place another linear cutter as close to the top level of the colorectal anastomosis. The linear cutter is applied and fired, leaving a small amount of rectal stump and completing the Duhamel operation. All that remains to be done now is closure of the colostomy incision, and that completes the procedure. My residents felt that with a proximal colostomy closure anastomosis and two distal anastomoses, it would probably be safer to leave an abdominal drain in this patient. And as you never argue with your resident, I conceded to their wishes. The child was kept on antibiotics for 5 days post-op. He had an uneventful recovery and has been followed up for 4 months without any problems. Thank you.